So thank you very much. It's actually quite interesting talking about cancer and COVID-19 in Australia, mainly because we thought that we were about 2 weeks or 3 weeks behind Italy, Europe, UK, and New York. So our country has spent a long time preparing for a wave of COVID-19 disease that we've seen in the Northern Hemisphere. Because of that, because we were behind, we have had the opportunity to make significant societal change with lockdown, or what we call stage 3 restrictions. So we're allowed to go out for exercise. Some workplaces are still open. Schools variably in different states. And what's actually happened is that's had a profound impact on COVID-19. I should also mention the fact that Australia is an island and so very easy to control borders. Initially, most of our cases were from people returning from overseas. We had people from China, and then returning from China, and then also a cruise ship, not the Diamond Princess, but the Ruby Princess, the actual sister ship. And they have actually accounted for most of our cases. So instead of seeing what you are experiencing in the UK or what's been experienced across Europe and America, and now sadly in many developing countries, we've been one of those countries where we've had very few cases. So to date, we've had 72 deaths. So that's tragic, but nowhere near the scale that's been seen overseas. We've had extensive testing, so the low death rate is not because we haven't tested. And we now look like we've flattened the curve with the R0 being under 0.5. We are wary, though, that Singapore also started with this very good control and now have a climbing rate due to circumstances in a particular part of their population, a very heavily, a very dense accommodation of migrant workers. So we are facing quite a different situation to the rest of the world, and the society impacts and the impacts on cancer patients are therefore quite different to what we were anticipating, and hopefully will be of interest to people because we have been waiting for this overwhelming situation, and it looks like it won't come. And if we continue to manage the situation well, we'll be in a different circumstance where we will probably have prolonged society restrictions, but no overwhelming of our hospital services. So the major populations of concern for us were our vulnerable population, and particularly our indigenous population, and especially the rural and the very remote and regional, and then the remote, and then the very remote communities. There's quite significant social disadvantage in those communities, and it was very much feared if COVID-19 got into the communities that we would have very poor outcomes. So there's been a lot of protection of those communities with quarantine, and the converse of that, and we can talk a little bit about how that might have affected those communities accessing cancer care. So around Australia, we've got a big country, a small population, quite spread out living conditions, and that's probably helped surpass even the government's expectation of how well we've controlled this pandemic. But of course, it's come at a huge economic cost, at a cost of mental health, domestic violence, many other issues that we've had to that we're facing at the moment. So because we had this time to prepare, thinking we were 3 weeks or so behind the rest of the world before a huge flood of COVID-19 patients really occupied most of our health services. As oncologists, we identified cancer patients as a vulnerable community, and we've seen the data initially out of China and now Europe and some data recently from New York. So we were fearful that cancer patients would do worse if they got COVID, that they were more vulnerable, and that we should consider our therapy and make adjustments. So I always talk about competing risk of death, something cancer patients are very familiar with, and the fact that COVID-19 appeared as a major competing risk of death, so much so that we would modify our usual weighing up of risks and benefits of our treatment. So we produced some local guidelines, and they were quite specific, as well as general principles. We went into alternates for different tumour types. Options, obviously no one's dictating treatment, but things to think about. Again, along the lines of more oral and subcutaneous therapy, more therapy delivered at home, treatment breaks for patients where that was an appropriate thing to consider. Similarly, our radiation colleagues produced shortened treatment schedules. So we were prepared with all of this. And in fact, we went through it at our cancer centre, every treatment of every patient to reassess it given this new competing risk of death. Now, no one made compromises that they thought would outweigh the benefits of cancer treatment, but we did move a lot of patients to community treatment at home through our hospital in the home service, and obviously our consultations through to telehealth. And that's had its own challenges, but also some rewards, and we're hoping that if we have good telehealth, that will continue as a mode of consultation beyond the pandemic where appropriate. So what's actually happened is in Australia, we currently have really pretty empty hospitals, a grossly expanded intensive care capacity, and a workforce redeployment for COVID teams. That's impacted on us in cancer because we're one of the services that has had to keep delivering. So all but emergency surgery was stopped for around a month, and that's about to be reintroduced. But we couldn't stop cancer care. So although we rationalised treatments and looked at reconfiguring our services, we continued to give cancer care to patients who need it. And we're now in the fortunate situation of ramping back up where we thought we would have to, make significant cuts because of patient illness or staff illness. So the other impact of having a very low community transmission rate has been that we've had really fairly low rates of quarantine due to contact. There have been some outbreaks, particularly early on, and one particular cancer ward in a hospital had a number of patients affected, and that affected actually a large number of staff, and that was really a lesson for us. But since then, we've had really very little impact on our capacity to work on staff leave or absences due to quarantine or due to illness. Again, quite different from the rest of the world. PPE also, there's anxiety about it and stockpiling, but currently we really don't need to use PPE for non-COVID patients. We don't need to wear masks in the street because the community transmission is really very, very low. Absolutely. I mean, this is a revolution that probably, has been greatly accelerated by the pandemic. When you think about our models of care, they really haven't changed for many decades. It's still very hospital-centric. It's still very much patient comes to the doctor. There's a lot of what we know of financial toxicity to patients. And the system's really very much around the services provided at a hospital. So telehealth is a way of really going into the patient's home, and it's actually, when the technology works, very gratifying. Usually the patient has a family member with them, and we can also patch in family members who are at other locations. So very important during the pandemic. But also going forward, we may be able to patch in somebody's daughter while they're at work, or relative living overseas who's a doctor and wants to know what's going on. We can also patch in interpreters. So telehealth gives you the opportunity to see the patient in their home, and patients, I think, have really enjoyed that. The visual gives you the ability, for example, I had a patient who had a herpes zoster infection, so I could see the rash. We can't examine the patients, and so we need to see some patients in person, but it really is very good. Where we've not been able to use video and have been relying on telephone, I think is quite inferior. I think you don't get all the non-verbal cues, and we're already missing touching people as a non-verbal cue. You also don't get to speak to more than one person at a time, although you can be on speaker, but that obviously affects sound quality. It's more difficult with an interpreter if you have a phone rather than somebody patched into a video conference. And we have great concerns about breaking bad news that way, or explaining new treatments. It may be fine for a follow-up of a patient you know very well who's generally got not many problems. So that's, if we're using video to communicate, we've got to think about health privacy, we've got to think about technology, having the bandwidth. And actually the biggest barrier that we've found is the rapid pace of change for the administration staff. And they are critical because they're the ones who are advising, troubleshooting the technology. So there's been a lot of resources developed for patients and carers and for our administrative staff about how important it is not not to default to the telephone, but to have a video consultation. We are very much hoping this stays as a major method of care delivery, not the sole method, but a major method in the future. It also helps patients not having to travel, not having to pay for parking. So there are a lot of other advantages. So initially, we proposed some guidelines, and the sort of more official bodies were a little bit cautious. That was way back in the beginning. So a group of a group of experts got together and wrote some guidelines anyway, that subsequently have been endorsed by the Medical Oncology Group of Australia, the Clinical Oncology Society of Australia, and they're being published in an upcoming edition of the Journal of Oncology Practice. We did find many guidelines were coming out, but they were fairly general, and we were concerned that at the height of the pandemic, cancer care may fall under the supervision of general physicians or even general practice, and that more specific information for them rather than general principles was warranted. Subsequently, many societies, ESMO, many other societies have put tumour-specific guidelines for treatment. So again, we were very fortunate in that we had this lead-in time. Interestingly, different jurisdictions made different decisions. Some decided to stop recruitment to all trials. In my centre, we took a very pragmatic and staged approach, and we haven't had to go into the more radical approach. So we stopped any trial where we thought it exposed the patient to an unnecessarily high risk of being in intensive care or being profoundly immune suppressed. But that's not the majority. And we thought where the trial offers a new treatment that the patient otherwise wouldn't have access to, or where the patient was going to have treatment anyway, we kept the trials open, kept a very close eye on it. Some trials were stopped because of the international situation, global trials, but many have continued, and we're very proud that we've been able to continue offering patients trials throughout the pandemic. It has brought up the fact that trials have been probably even slower than usual practice to adapt to new technology. So principles of GCP still require in-person signing of consent rather than witnessing and even recording by video. So again, we're hoping as a sort of silver lining out of the pandemic that streamlining of procedures for trials, such as consent by video consultation, local bloods. Many trials insist on having central bloods, which is fine if it's for a particular biomarker, but your standard central bloods, there's really no reason to need a full blood count or standard biochemistry centrally. Okay, so the one other concern that we have is, although we haven't had this huge load of COVID-19 patients, we have had the same impact that's been felt around the world of the general public not going to the GP, not going to the emergency department. And so we are fearful that there will be a rise in cancer diagnoses once the restrictions are lifted. And there's now active campaigns encouraging people to present if they've got symptoms. GPs saying we are open for business, even if it's telehealth. So although there's a reason for many patients to stay away from hospitals in Madrid or London, there's not the reason here. And yet we're seeing that same phenomenon of people being too frightened. And we do hope that nobody puts off having cancer symptoms investigated and no one is disadvantaged or presents later than they should because of this. Particularly in Australia, we do have the capacity to look after people and not delay their diagnosis or treatment. So the other impact that we're concerned about, and I think is a concern around the world, is the impact on our junior medical staff and our oncology training registrars and fellows. A lot of people have been pulled into COVID work overseas, and in fact, even in our COVID teams here. And we are hearing about ward rounds with lots and lots of registrars and very few patients. So I'm concerned for oncology training that it won't be as normal. It isn't as normal. And we need to think about that carefully, how we look after our trainees and registrars, how we compensate for their time that's lost, the impact that this will have on many aspects of their lives. And I think it's really a topic that we can address here in Australia, again, because we don't have that acute pressure of what and the overwhelming patient loads. But we do need to look after our trainees. They have had a crash course in rationalisation of therapy. They're really, I think, got a good understanding of competing risks and of really evaluating the benefit of therapy. Perhaps we get a little complacent in oncology and give things a try where there's perhaps very little benefit, and that's all been changed. The other impact that I should talk about is the impact on patients and doctors and families of the very strict visitation rules. So we have, like our international hospitals, restricted very, very tightly the number of people who can come in and visit someone in hospital. And for a cancer patient, particularly in the last stages of their life, that's had a profound impact. And we have had newspaper articles about people dying alone, not being able to say goodbye, and not because they've got COVID-19. So there's been a lot of concern about the impact of that. It's a disaster for our indigenous communities, where dying alone is really one of the worst things that can happen, and where community and family is so important, but it's important to all patients. So that's been something quite unique to live through. I don't think anyone's lived through an experience as a doctor or a patient where we've had such strict limit for visiting. We've now got video, not consultations, but video visitations. But again, it's not quite the same. Again, we're in slightly different situation. We don't have that acute distress that we're hearing about from doctors on the front line in countries like the UK or Italy or Spain. But we are facing a longer course, perhaps. We're facing the fact that we have had to make change very quickly. We're concerned our health budget will be less for cancer because of the COVID-19. So there is a lot of stress around employment, not so much for doctors, but trial staff, etc. The future of trials and the income from trials that support our trial staff is also concerning. We've had to learn to work from home and keep our teams and our collegiate nature, video conferencing, multidisciplinary meetings as well. So lots of learning at a time where families are stressed, and doctors are part of families. People haven't seen their elderly parents, or people have young children at home that they have to homeschool. So that affects patients and affects our doctors. I think the thing that is spurring us on is how well Australia has done, and the reward that we've got from this, the policies that have been implemented. There was a lot of talk of needing 80% compliance with the policies, and we've had, over 95% compliance. And Australians are not usually very compliant. I know some cultures are. In fact, that's been touted as a major reason why Taiwan has done so well, and other countries like Germany, but that's not usually an Australian characteristic. So my advice is to keep connected, keep talking, keep listening, and stay connected with not only your fellow countrymen, but internationally. And just one more word, if I might say, Australia's a long way away, and we're not going to be able to travel for a very long time. And we, in particular, enjoy going to our conferences, to meet our colleagues, to work together, to socialise, to learn what's going on in other parts. So there are many seminars we can participate in by video, but it's not quite the same. So that will be a big change for us and may affect us more being so far away and with our borders probably remaining closed for some time. So we hope we stay connected with the rest of the oncology community around the world.